Hello and welcome to Natus Neurotraining Academy webinar. I'm Brenda Steffens. I'm the Director of Global Medical Education at Natus Neuro, and it's my pleasure to host today's educational webinar. Also joining me today is my colleague Francesco Mucci, who's a clinical specialist with Natus. Our webinar today is presented by Professor Louis Maillard and is entitled Principles of Pre-Surgical Evaluation in Drug Refractory Epilepsy Patients. Professor Maillard is head of the Patrick Chauvel Epileptology Unit at the University Hospital of Nancy, which is a European reference centre for rare and drug refractory epilepsies. He's a professor of neurology at Lorraine University and a member of the clinical and neuroscience research team, Lorraine University Centre National de la Recherche Scientifique. Professor Maillard also heads the scientific board of the French Clinical Neurophysiology Society and is a member of the ILAE Task Force on Diagnostic Methods in EEG. Louis Maillard has been an instructor and a tutor and faculty member at numerous international workshops and congresses on SEEG and drug-resistant epilepsies, and will be chairing the special interest group of the AES dedicated to SEEG in 2024. So with this, it's my great honour to turn the presentation over to you, Professor Maillard. The audience is yours.
Hello, everybody. It's a great pleasure to do this presentation to such an audience, and I want to thank Brenda and the Natus Medical Education Department. So today we will review in 55 minutes the principles. Maybe I should have written the grounding or founding principles of pre-surgical evaluation, because we will review really the basic to take into account the heterogeneity of the audience, but you will see through a few clinical cases also that we will go quite further in the topic. So first of all, I want to remind you the two grades of the epilepsy surgery. Let me start my chronometer. Okay, and of epilepsy surgery and hence of pre-surgical evaluation. These two grades are to achieve a long-term seizure freedom in operated patients and to guarantee or to consolidate stability or even improvement of cognitive functions. Regarding this second objective of stability or improvement of cognitive functions and functional mapping of the epileptogenic zone, we will not have time to go through this second part of the topic, which maybe could be a dedicated, the topic of a dedicated course. So today we will emphasize the first objective, so how to achieve long-term seizure freedom, and basically the intermediate step to obtain long-term seizure freedom is before surgery to be able to delineate and localize the epileptogenic zone, which here can be understood as the necessary area to be removed to free the patient from seizure. So first of all, let's review the indications. So as you all know, indications of epilepsy surgery and pre-surgical epilepsy workup are the following. First of all, the epilepsies must be focal, so comprise focal onset seizures. It have to be drug resistant. I will also spend some time on the fact that this epilepsy surgery concerns patients who have invalidating epilepsy. Of course, there is no point of doing surgery in patients who live with epilepsy which is not invalidating. And last but not least, these epilepsies, the etiology of these epilepsies has to be structural, and this structural origin, and we will review through this point a little bit, has to be, or is sometimes proven, but sometimes before surgery it is only a presumed structural origin. So now we will review each one of these four criteria, very important criteria. So first of all, drug resistance. As you know, how can I hide this? Okay. As you know, a drug resistance is defined as a failure of adequate trials of two tolerated and appropriately chosen anti-seizure medication schedules to achieve seizure freedom. The prevalence of drug resistance, as you know, is overall 33%, 33 to 35% of all patients. This cutoff of failure of two adequate seizure to obtain seizure freedom is based basically on a prospective observational study that determined that after the failure of two drug regimens, as you can see on the histogram on the left, that is taken from the paper from Kwan, the probability, the chance of render patient seizure free with a third line medication drop dramatically to 4% of the entire cohort. In everyday practice, it is 1 or 2 years are necessary to diagnose a drug refractoriness. And it is striking that in all countries of the OCDE, the mean duration before surgery among adults is in average 20 years. So there is a huge gap between this time necessary to diagnose a drug refractoriness and the time when patients are referred for effective surgery. And this is something that we question the way our health system are organized and the way patients are referred to epilepsy surgery centers. So this could be a matter of discussion. The second point is that these seizures these epilepsies have to be invalidating. So you know, of course, that drug refractoriness is strongly correlated with handicap, with handicap in everyday life, in professional life, in emotional, affective life. But sometimes it is not always, in every patient, it is not so simply correlated. So this has to be weighted individually. And as you know, in these epilepsies, there is a higher mortality. So the risk of the increased risk of mortality has to be evaluated, assessed individually in each patient. And then you have to consider the cognitive, either developmental or developmental effect of the epilepsy, the psychiatric comorbidity, the social impairment, and finally the reduced quality of life. So all of these aspects that are part of the definition of epilepsy have to be taken into account individually in every patient before proceeding to epilepsy surgery. And this is also one of the purposes of the pre-surgical workup. I will not insist on this, but keep this very important fact in mind. And then these epilepsies are of structural origin. And I mentioned presumed or proven. Indeed. So first of all, yeah, as it has been shown in this big multicentric pathological paper written by Blunker and published by Blunker in 2017, the most frequent structural etiology of drug refractory epilepsy, focal epilepsy in children is focal cortical dysplasia, and while hippocampal sclerosis are the most common histopathological findings in adults. In fact, in our epilepsy tertiary centers, even in adults, now the malformation in a large understanding of this word, malformation are in fact the most frequent etiology also in adults. And interestingly, as you can see, in 2021, 48% of patients explored with a CEG of 291 patients explored with CEG, and 30% of 4 or more than 400 operated patients had in fact a normal MRI, where MRI negative cases after a proper MRI scan and after a multidisciplinary discussion of the MR, especially with dedicated neuroradiologists. I will come back to this point a little bit later. So now, what do we mean by epileptogenic zone. First of all, maybe the most important information is that the epileptogenic zone, whatever the definition, you will see that there are two definitions, both of them are functional definitions, okay? So there is one historical electrophysiological definition proposed by Banco in the 60s, and I quote his words. This epileptogenic zone, he defined it as the area of primary organization of the ictal discharge. It is very close to the seizure onset zone definition, but it's a little bit different, and it should be more understood as the area that is identified and delineated based primarily, of course, on the initial discharge, on the area involved by the initial ictal discharge, but we usually take into account also the interictal activity, the lesional activity, data from electrical stimulation. So it's a little bit different from the usual seizure onset zone. And then there is this theoretical definition proposed by Luders later on as the cortical area whose resection is necessary and sufficient to cure patients, which is actually very theoretical, because before surgery we are not sure that indeed patients that we will achieve seizure freedom with resection of a predefined epileptogenic zone. And after surgery, we are never sure neither whether this area of resection could have been maybe smaller. So, in the next in the course of the presentation, when I will use the word epileptogenic zone, I will rather refer to the first definition, which is an electrophysiological definition based on anatomo-electro-clinical correlations. So now, after having seen the indication of pre-surgical workup, why do we need, practically, why do we need a functional definition of this epileptogenic zone? So I propose you to go back to these figures of MRI negative cases. There are several reasons, but the first one is the MRI negative cases. As you can see in the beautiful paper from Eileen McGonigal in 2007, which was a retrospective case series of MRI negative cases in Marseille, published in 2007, 43% of the patients explored with a CEG were MRI negative cases, and 33, so 1/3 of the operated patients were indeed MRI negative, with a proportion of patients of seizure-free patient, Engel 1A, was roughly the same between MRI negative and MRI positive. And interestingly, when I looked back at our own cohort in Nancy in 2021, I had exactly the same figure at 48%. Almost half of the patients explored with a CEG were indeed still MRI negative, despite the huge progress in the MRI techniques, in the sequence, in the way we analyze visually, but also in the way we quantify the modification of signal. And the same for the percentage of operated patients. 30% of the more than 400 operated patients were still MRI negative. And in this cohort from Nancy, it's interesting because we started the epilepsy surgery program in 2000, but we started the SEEG in 2007, exactly when the paper from Marseille was published. So two different periods, okay? The first 10 years of the millennium and the second 10 years, the second decade of the millennium, and the figures are exactly the same. So we have to deal with a huge proportion of patients who are MRI negative. So if there were only one reason for a functional definition of the epileptogenic zone, this could be this one. And in fact, indeed, when looking at the histology of the resection, as you can see, more than 90% of patients, of operated patients, actually have a pathological lesion identified on the resection piece. So there is a discrepancy between the MRI visible abnormality or absence of abnormality and the high rate of structural lesion on histology. there are, of course, many other reasons why this surgery and the definition of the epileptogenic zone is functional. And the second one that I want to propose to you is that there are lots of situations where the limits of the structural abnormality are not concordant with the limit of the epileptogenic zone. And here you have one example, which is taken from a multicentric retrospective study that I published in 2017, focusing on polymicrogyria. So polymicrogyria are, as you know, spatially extended malformation whose epileptogenicity is very heterogeneous. And this abnormal cortex can even be functional. And in this retrospective paper, we show that the concordance between SEEG-defined epileptogenic zone and extension of the structural abnormality on MRI was fully concordant in only 16% of patients. It's huge. It's very small, sorry. So the percentage of discordance, of complete discordance or partial discordance, is very important, more than 80%. The third example why we practically need the third situation which explain to you or illustrate to you why we need a functional definition is that there are also many situations where we are facing several structural abnormalities with a potential epileptogenic, with a epileptogenic potential, but only one epileptogenic zone. And this is the case in patients with multiple cavernoma or with Bourneville tuberous sclerosis. Here, this is a figure taken from the paper from Andrew McNeil, who showed that in these patients there were two types of epileptogenic zone in organization, and I will focus on what they call the focal tuber organization, where the resection of a single tuber could achieve 80% of angle 1A. And there were some electrophysiological and functional characteristics that were defined in the paper, and meaning that all the other abnormal structural abnormalities were in fact non-epileptogenic, or if they were epileptogenic, they were not drug refractory. Okay, so this is another situation where which clearly shows that we definitely need a functional definition of the epileptogenic zones. So now let's review the different steps of the phase 1 non-invasive pre-surgical investigation. The core of the pre-surgical investigation is the video-EEG, which will allow you to analyze interictal discharges, ictal EEG, ictal behavior, and the correlation between ictal EEG and ictal behavior will allow you to make hypothesis, anatomo-electro-clinical hypothesis. And this is really the core of this functional definition of the epileptogenic zone. And then, as you know, high definition cranial MRI, the standard now is to perform a 3 Tesla MRI, but even with a 1.5 Tesla MRI with the appropriate sequence, you will achieve a good resolution, and also a fluorodeoxyglucose, positron emission tomography, which has increased very much the yield of imaging findings in the last 20 years, at the condition provided that you are able to merge the PET scan with the MRI and see closely the correspondence between the gray matter, the sulci, and the metabolism. So these two steps are of course mandatory. I will add also as mandatory a pre-surgical neuropsychological evaluation and psychiatric evaluation. These two steps are really, really mandatory, and they are very important because they will allow you to assess the functional concordance between the neuropsychological deficit and the epileptogenic zone and the structural lesion. And this is a very important point to take into account to predict the post-surgical neuropsychological outcome. And finally, the psychiatric evaluation, which should be also systematic before surgery, because be aware that epilepsy surgery can worsen a psychiatric condition that is not stable before surgery. Be aware also that the effect of the surgery, even if it is a success in terms of seizure freedom, can be completely overcome by an unstable psychiatric condition that would pre-exist or would appear after epilepsy surgery. And finally, you have to know that a history of for example, of psychosis or severe psychiatric conditions is a predicting factor of bad result, of bad outcome in terms of seizure freedom. Okay, and then there are these two modalities which are recommended, but not necessarily mandatory: the electromagnetic source imaging, so magneto-electroencephalography, or electrical source imaging, that will allow you to modelize in 3 dimensions in the anatomy of the patient, the generator of the interictal or even the ictal discharges, and the functional MRI to, for example, to determine hemispheric dominance or preference for language. Okay. So what are the principles of anatomo-electro-clinical correlation at the end of phase 1? So as I already mentioned, you by carefully analyzing the video-EEG, you will describe a double dynamic, spatial and temporal, that relates the sequence of clinical events to the sequence of electrical events. Okay, I'm used to. I like the image, the metaphor of language. Semiology is to identify an epileptogenic zone. Semiology is like a language. It's like a syntax. Yeah, so understanding semiology is like understanding language. It is based on a syntax of symptoms. So symptoms that occur, a series of symptoms that occur in an orderly manner. You cannot rely on a single symptom, either electric or clinical. You have to consider the entire sentence. And then based on this description, electroclinical description, you will make inferences based on the integration of these electroclinical correlation into a corpus of anatomo-functional knowledge. So doing pre-surgical evaluation requires to have a fine knowledge of gyral and sulcal anatomy and functional anatomy, and in the past years this reasoning has been very much enriched also by all the data from tractography data about structural connectivity and even functional connectivity. And last but not least, the empirical experience also. Okay, you will, those of you who already do pre-surgical evaluation, you will understand what I mean, that sometimes you have like prototypal cases on which you learned a lot, and that will help you to really to improve the exploration of the next case, which is quite similar, even though a little bit different from the previous one. So all these steps end up in with the anatomo-electro-clinical hypothesis regarding the presumed epileptogenic zone. And then I would like to add a third step, which is the concept of anatomo-functional concordance. When there is only one anatomo-electro-clinical hypothesis, which is concordant with the structural and functional imaging and neuropsychological findings, then a direct surgery is possible. Typically, mesial temporal lobe seizures with hypocampal sclerosis. Okay, so when all the data, anatomo-electroclinical data, and are concordant with structural imaging, functional imaging, and neuropsychological findings. So this is summarized in the very simple algorithm on the right. If you can see here, so when at the end of the phase 1, if you have a single hypothesis and you have an anatomo-functional concordance, then you can proceed directly to direct surgery. In all other cases, in my view, it's either a contraindication for curative epilepsy surgery, or it can be an indication for SEEG. We will review this a little bit further later on. So example of direct surgery after phase 1, Fabien is a 30-year-old right-handed man. He has a history of complicated febrile seizure, first non-febrile seizure at 21, and the ictal semiology comprised the shivering, a déjà vécu sensation. Contact and language are initially preserved, and secondarily in the course of the seizure, which has very slow dynamic, you will show a chewing and gestural automatism. So let me share with you the video. I don't know if you can hear the sound of the video. I don't think so. When we did the testing, it did not work, but I will tell you what's going on in terms of the sound. Anyway, it's in French, so I will translate you what's going on. So, so the nurse get into the room because they saw on the EEG traces the beginning of the seizure. So the patient is able to execute the instruction, the verbal instruction of the nurse, and is able to name the object, so a key, a watch. And the patient is saying that now he's feeling the initial sensation that usually warns him that he's having a seizure. And you can see now with a very slow dynamic, the beginning of the chewing automatism, the patient is a flush. As you can see, even though the automatism are there, there is no loss of awareness, no loss of contact, the patient is still very reactive and react from an adapted manner. So you see also this striking, very slow dynamic of the emergence of the semiology. Okay, the chewing automatism, and the patient is still able to answer the question properly. So now he's getting a little bit more agitated. Yeah, you can see a manipulation behavior. Okay, and now the emotional disturbance. I must say that not all mesial temporal seizures in France comprise the French symptom. Okay. Okay, we will stop now. So you see the very long duration of the seizure and very late and secondary chewing and gestural automatism, and somehow there is a loss of verbal contact at the end of the seizure, but there is still interaction with the examiners. So in this case, in this very typical case, you can see on the EEG on the left side a right temporal and temporobasal rhythmic theta discharge, and so the electroclinical correlation here points towards one single hypothesis of right mesial temporal seizures. And this hypothesis is completely consistent, concordant with the structural abnormality here, with atrophy and sclerosis of the hippocampus and the hypometabolism, and completely concordant. So there is an adequation between the neuropsychological deficit, because in fact there is no language deficit in this right-handed patient, no episodic verbal memory deficit, and inconstant visuospatial episodic memory deficit. So everything is consistent with a single hypothesis, which explains very well the neuropsychological profile of the patient. So this is the ideal situation where you can proceed to direct surgery, either selective mesial temporal structures resection, open surgery, or more recently with the laser interstitial therapy. Okay. So now I would like to ask you a few questions. Now we are not anymore in this very simple case. I would like to propose you a very different clinical situation, electroclinical situation, and ask you in which of these following situations would you indicate intracranial SEEG exploration instead of direct surgery in the pre-surgical workup? So answer, so yeah, so you will now have the sondage, the poll, the situation when you indicate intracranial, in that case SEEG, so stereo-electroencephalography exploration. So second proposal, left dominant basal temporal seizures, concordance with the left posterior inferior temporal gyrus dinette. Third situation, left hippocampal sclerosis associated with typical left mesial temporal seizures. And last proposal, right posterior part of the superior temporal gyrus cavernoma associated with seizures characterized by a left hemibody-algic sensation. Okay, so in those cases, I don't want you to consider that there is a right or wrong answer. It's more like, what would we do here in Nancy and why? So in the first case, MRI negative left dominant temporal epilepsy, you were a majority to answer yes, you would proceed to SEEG. This is indeed what we would do because we want, first of all, we want to make sure that this mesial temporal presentation of the seizure is not a propagation from a silent area in the basal temporal cortex, in the ventrotemporal cortex, or in the lateral temporal cortex. There are some areas which are clinically and silent. And the second reason, indeed, is the for functional purposes, because you all know that resecting is an hippocampus that looks structurally normal on MRI could have deleterious cognitive effect on a long-term outcome after surgery. So I agree with the majority of you. In the second proposal, a majority of you did not proceed to SEEG. I tell you that indeed the onset of the seizure is concordant with the structural abnormality, which is typical of dysplastic neuroepithelial tumor. But I want to draw your attention to the fact that in those dinettes, first of all, the dysplastic tissue, which is the most epileptogenic, is usually in the surroundings of the dinette and not in the most visible structural abnormality, first of all. And second, very important point, the left part of the inferior temporal gyrus is very close to the basal temporal language area and to the visual word form area. And based on phase 1 electroclinical correlation, it's very difficult to know whether these highly functional areas are involved at the onset of the seizure or not. And so for functional reason, in this case, because we are very close to a highly functional cortex whose resection can be very deleterious on language, in this second case, in Nancy at least, and I think in many centers in France, we would proceed to a SEEG. But it's open to discussion. In the third case, you were 34% to propose a intracranial exploration. Well, in this case, you have a concordant structural abnormality in the hippocampus and left mesial temporal seizures. So maybe both answers, yes or no, were valid, depending on whether you had a neuropsychological deficit that was concordant with this clinical picture or not. In case of discordance, indeed, SEEG could be useful, but in the majority of cases, if they are concordant, then we would proceed directly to surgery, exactly as we have seen in the previous case, except that, of course, the previous case was on the non-dominant side. And in the last proposal, a majority of you did not proceed to intracranial exploration. And this is very interesting because I will show you a case corresponding exactly to this situation. The problem in this case is that the patient reported and we recorded seizures characterized with a left hemibody algic sensation. So this sensation reflects clearly an involvement of the right insular, the right insulo-opercular parietal junction. And as you know, so based on this data, you would have to remove this area, but surgery in this area, in the insulo-opercular region, posterior insulo-opercular region, is very risky in terms of risk of neurovascular of stroke, of deep arteries stroke, deep perforating arteries stroke. So you have to know, okay, shall I spare this area, or shall I take into consideration the initial symptoms and include this area in the resection? And in terms of risk for surgery, it is very important. So in this case, I would say, to be able to determine with the highest degree of certainty whether we can spare or not this insulo-opercular junction, posterior insulo-opercular operculum, we would proceed to SEEG. But again, I'm open to discussion, and this is just examples to show you the way we reason and the way we integrate the intracranial exploration in the pre-surgical workup. So now, after this introduction, I propose you to review some of the most frequent situations where we proceed to intracranial exploration. So quite obviously, when there are several possible anatomo-electro-clinical hypotheses regarding the presumed epileptogenic zone, but also when findings of the phase 1 investigation are not all concordant toward a single and well-delineated epileptogenic zone. And finally, when the localization of the presumed epileptogenic zone overlaps or is in the vicinity of a region with a high risk of post-surgical functional deficits. So these regions are primary cortices and language or memory networks. Okay, so when you take into consideration all these clinical situations, you will see that indeed, if you want to optimize your pre-surgical workup, indication of SEEG are quite large. Again, these different points are the expression of an expert opinion. It's not, and so it's open to debate and to discussion. So the objective of the SEEG are in fact exactly the same as the objective of phase 1, but with a more accurate tool. And again, in this part, we will focus on the epileptogenic zone localization and delineation purpose. So how do we proceed to SEEG implantation? So you have to keep in mind when doing SEEG implantation that the purpose is to localize and delineate, not just localize, but delineate also the epileptogenic zone. So the endpoint is to define the zone. But from a physiological point of view, and also based on the technological physical constraint of the method of the SEEG, in fact, what we identify with the SEEG is a network. So an assembly of cortical areas that are strongly connected together and that are involved sequentially or sometimes at the same time in the emergence of the electroclinical discharge. So keep in mind that the concept of epileptogenic networks is linked to the SEEG methods, because the SEEG methods does not offer you a uniform, homogeneous covering of all the cortical areas of the brain, obviously, but it offers you the sampling of functionally related but spatially very limited regions of interest that you will explore with your depth electrode. So these regions have to be chosen after a careful analysis of the sequence of clinical and EEG events. And this is something very important. The most difficult part in SEEG is not the SEEG itself. It is a phase 1. It is to have to rely on a high quality phase 1 investigation and high quality recordings of EEG video and analysis of electroclinical symptoms. And very careful review of the structural and functional imaging. And these clinical and EEG events are understood as emerging from the abnormal activation or disruption of functional networks, as shown in this scheme taken from the very nice review paper from Fabrice Bartolomei in 2017. And this, and then the analysis of the the sequence of electrical and clinical events will allow you to hierarchize the different regions of this network as part of the epileptogenic and propagation network. And then within this network, you will have to determine somehow which herbs are necessary for the network to function, and which part of the network has to be removed in order to shut down this epileptogenic network. Okay, so there are this might seem a little bit theoretical, but in fact, these are really the different steps of reasoning when doing when trying to devise a SEEG implantation and then to interpret the SEEG findings. So we usually use between 8 to 15 trajectories. This scheme is designed during a preoperative multidisciplinary planning involving both neurologists, neurophysiologists, and neurosurgeons. The implantation duration is in fact quite short. It's between 2 and 4 hours. Actually, what takes most time is to do the imaging, perioperative imaging. Monitoring starts the same day in Nancy. The patients are implanted in the morning and the monitoring starts in the afternoon. We do continuous recordings and the SEEG interpretation, we rely both on spontaneous seizures and on findings obtained from electrical stimulation, seizures, electrically elicited seizures, behavior for the functional mapping, individual functional mapping, and there are some more refined tools that we are progressively integrating in our clinical reasoning, like cortico-cortical evoked potential and estimation of effective connectivity. We use also for functional mapping intracerebral evoked potential. I will not go through this part. The duration here in Nancy is between 4 to 8 days. In most centers, it's a little bit longer. It can last up to 2 or 3 weeks. And before removing the electrodes in France, at least, we will very frequently use the electrodes delineating the epileptogenic zone for radiofrequency ablation. So now let's go through a few examples for the next 10 minutes left. Cedric is a right-handed male, 32 years, first seizure at 16, cluster of seizures, several days a month, and have a look on the ictal semiology obtained from anamnesis. So isolated left eyes and head version, sometimes followed by a complex automatic behavior of prehension, manipulation, and dressing. MRI and FDG PET are negative, and he has a left language dominance on the fMRI. So from the history, we can make a hypothesis. So I must add that these seizures are very brutal, very brief, with a very brutal paroxystic onset and paroxystic offset, and very quick recuperation, a very quick recovery. So from the history, we can make hypotheses about involvement of IPSI or contralateral premotor convexity, basically the frontal eye field, for example, so lateral premotor. And this complex automatic behavior of prehension manipulation to orient us towards an involvement of the orbitofrontal and frontopolar area. Remember that in this case, we had no information from imaging, okay? And this absence of information from imaging does not contraindicate to carry on the investigation as long as you have strong electrochemical hypothesis. So here is a screenshot of the EEG and of the initial phase of the clinical semiology. You have this left eyes and head version, and here before the EMG artifact here that blurs the interpretation of EEG, you can see a preictal spike, which is clearly a bilateral frontal with a slight left predominance. I will show you the clinical sequence during the SEEG. So this is a very old case. So as you can see, we used at that time quite a rough scheme to delineate the implantation. This was just an indicative scheme. The important phase was the part where the neurologist and the neurosurgeon together determine the trajectories of the electrodes. So not only the entry point or the target, but the entire trajectory. And as you can see, we explored the left prefrontal region with an emphasis on the frontal pole and with the orbitofrontal cortex, but also the superior frontal prefrontal gyrus and a sampling of the cingulate gyrus and the superior frontal gyrus here. We usually try to use orthogonal trajectories just because it makes more sense. It is more relevant from a surgical point of view when the surgeon, to help the surgeon when the surgeon will perform the open surgery, to be able to use the entry point of the SEEG electrodes to map his way to the resection, to the epileptogenic zone. And also for you and for me, it's of course much easier to understand the 3D configuration of the electrodes if they are in the usual 3D plan. Okay, when you look at an MR, you usually look in the coronal, sagittal, and axial plan. So if somehow you have fancy trajectories, it is almost impossible to reconstruct, for our mind to reconstruct in a 3D way the volume of explored by your electrodes. So now I show you a short seizure. Again, in this case, I will translate you in English the discussion of the patient. So now on the EEG on the left, you see the seizure started with pre-ictal spikings and then polyspike discharge and then rapid low voltage discharge, very, very fast low voltage discharge. And you can see the clinical onset with the left eye deviation and this prehension manipulation behavior. He will grasp and manipulate all the objects that are in his immediate surroundings. You see, so the bottle, the cables, and then the table with the foot that he pushes and pulls back to him. Very short. And now the seizure is almost over, and the examiner comes in the room and is interacting with the patient. Okay, so you have all the characteristics of a prefrontal seizure: very short, very brief, very fast recovery, proeminence of hyperkinetic movement, and here these movements have a strong naturalistic tone. Okay, they look very much natural. The EEG here, as you can see, we had the initial pre-ictal reinforcement of interictal activity, and then the polyspike discharge followed by a fast low voltage activity. The fast low voltage activity was propagating very quickly to this superior, this frontopolar electrode here. And we were able to reproduce the spontaneous seizure by high frequency but low intensity, very low intensity focal stimulation of the external contacts of O'. So in this patient, we proposed this resection scheme, and this is the early post-operative MRI. And in this patient with, again, which was MRI negative and PET negative, with histology found the focal cortical dysplasia type 2B. We have a 12-year-old follow-up in a patient who is angle 1A free of drug. Okay, so this is a situation where even in the absence of an MRI detectable epileptogenic lesion, if you have a strong hypothesis about a structural origin and about a localization of the seizure onset and of this presumed focal dysplasia, SEEG will allow you to localize and delineate the epileptogenic zone. Let me show you a second example. Guillaume is a 13-year right-handed boy, first seizure at 3, 4 seizures per month. He has no warning, no warning, but he has the initial symptom is a conscious tonic asymmetric contraction of the forelimbs with a secondary left clonic head. So again, from the history, we can make a hypothesis of an involvement of the IPSI or contralateral mesial premotor cortex, SMA, based on this asymmetric tonic and conscious contraction of the forelimbs, and a secondary involvement of the left primary motor cortex. So the second part of the clinical semiology somehow gives you some evidences, some hints about the lateralization of the onset. Okay, so it's very important to consider the entire dynamic of the seizure, not just the onset. So now let me show you the seizure that was recording during phase 1. So you see very paroxystic onset, asymmetric posture, tonic posture. So the nurse asked Guillaume to remember the word watch. And you see the clonic, bilateral, but predominating on the left arm at the beginning. And right immediately after the end of the seizure, the nurse asks him, "Okay, which word did I ask you to remember?" And he's immediately able to recall watch. Okay, so now look closely at the pre-ictal EEG, and as you can see, there is a pre-ictal reinforcement of periodic fast spike and wave, which project in this reference montage on CZ and F4, C4. So this localization is consistent with the generator in the well, CZ projects really nicely over the SMA and the primary cortex. Okay, and then you have the artifact here of the MG, and before this artifact you have a rapid but not very rapid and not very low voltage and quite extended polyspike discharge here. If you look closely at the MR, there are some axial slices. You can see something, I guess, here, okay, in the left frontal lobe, okay, this hypersignal in the flare sequence. So my question here is, in this case of structural drug refractory focal epilepsy, is this case MRI negative, yes or no? So
okay, just launching the poll. So
yep.
Please answer with a yes or a no.
Thank you very much. Can you share my screen again, and
yes.
Let's go back to and I go back to this slide. So I'm quite amazed and very happy that the answers were about roughly 50-50. So 55% of you responded yes, it's an MRI positive, or the question was MRI negative. So the majority of you responded yes, it's an MRI negative, despite this abnormal structural abnormality. But I guess that most of you that responded it is an MRI negative did respond that it is MRI negative, because indeed this structural abnormality is at a location which is completely different from the expected location derived from the electroclinical correlation. Okay, we discussed quite deeply the fact that ictal semiology was a semiology of SMA seizure, of right SMA seizure, and the EEG, the pre-ictal EEG, which looks very much like a dysplastic activity, project on the vertex, on CZ and C4 and F4, which are the electrodes covering the SMA and not the frontal pole. If the seizures were started from this structural abnormality in the right frontal pole, we would expect the abnormality to project on FP2 or FP2F4, but definitely not on CZ. Okay, so if you don't take into consideration the anatomo-electro-clinical hypothesis and the concordance with the structural lesion, you would answer no, it's not MRI negative because there is a structural abnormality. But in this case, I would say yes, it is an MRI negative because the structural abnormality cannot explain the emergence of semiology, what we see from the electroclinical semiology of the seizures in this patient. So I understand that my question and my answer are a little bit provocative, but they are provocative purposefully, because again, when considering a structural abnormality and the causality of this structural abnormality in the epilepsy, you have to consider the concordance between the location of the abnormality and the electroclinical hypothesis, which in this case were very strong. We had very localizing electrical and clinical semiology. And so indeed, in this patient, we did a CEG. Because of this discordance, we did not propose, of course, a resection of the structural frontopolar abnormality, and we had electrodes in this structural abnormality, which recorded very slow activity, but no dysplastic activity. And in the SMA, in the right SMA, where there was no structural abnormality, we had a typical dysplastic activity with a continuous periodic spike and wave discharges. We did not have spontaneous seizure in these patients, but we elicited at very low intensity, 1 milliamp, typical clinical seizures when stimulating in the right SMA, but not when stimulating in the structural abnormality. We did a very small resection in the right SMA, and the pathology found an FCD type 2A. We have 8-year seizure outcome is 1D because he had some provoked seizures when he stopped medication. In fact, when we stop medication, he's having primary motor seizures. So my guess is that there has some remaining cortical tissue close to the primary motor area that we did not remove, but the surgery was sufficient enough to make him seizure-free, provided that he's still taking medication. So here we have a very interesting case where the MRI visible lesion, the MRI abnormality, is completely discordant with the epileptogenic zone, as you can see. So this is a perfect illustration of the fact that you don't always, that epilepsy surgery is a functional neurosurgery and not a resection of a visible lesion, okay? And it's very important. And the last case corresponding to one of the proposals that you had in the first quiz. So it has a left hemibody sensation. Well, it was not painful, but it was a hot sensation, so it has the same localizing value, and then perioral paresthesia, and then he was able to warn, and we had a semiology of chewing without loss of consciousness. So we can make some hypotheses from the history, and here you have the cavernoma here in the superior temporal gyrus and involving the inferior part of the insula. So the semiology, the left hemibody hit sensation would reflect an involvement of this superior part of the insula and insulo-opercular junction here. Here is the aspect of the discharge on a surface EEG. I will not show you the video of the clinic. It is not necessary, but there is clearly two phases in which the patient is able to warn and describe the sensation. And this, in this case, and we also had as you can see, the seizure started in the electrode in the internal contact of U and T, and we had electrodes covering the pourtour of the cavernoma. You see, U and T is here, and so the seizure started anteriorly to the cavernoma, and anteriorly, quite anteriorly, not only U but also the internal contact of T in the anterior. But no, sorry, the external contact of T, so the anterior part of the superior temporal gyrus. Okay, and then I don't show you the video; it's too long. We don't have time. And then in the second time, sorry, this was the first type of seizure. Okay, and it could remain in this electrode. And we had the second type of seizures. With the same type of onset, but on T and U, but a very quick propagation to the mesial temporal structure, A, B, C, internal contact of, here of, can see R, so the anterior insula, but this was a secondary involvement, okay? Very fast, but secondary. So this is so here, U and T, you have the onset, and the secondary propagation involves the internal contact of A, of B, so mesial temporal structures, and R here in the insulo-opercular region near the central region. So you can see here that all these electrodes are quite far from the cavernoma itself. And of course, indeed, we know that the seizure does not start from within the cavernoma, but on the periphery of the cavernoma. But then if it starts on the periphery, where in the periphery? if we hadn't done a CEG, we would have involved, for example, we would have involved in the resection without a CEG the region explored by O, but O did not show initial involvement, and in fact the onset was more anterior and in this area. Okay, so this patient had a resection here. So this is a plan for the resection. We decided, of course, to remove the cavernoma, but to extend the resection in the anterior part of the insula and in the anterior part of the superior temporal gyrus, as shown here. And what we found was a FCD. So it was actually it was a FTD type 3C, because it was a FCD tissue associated with a cavernoma. Okay, so I believe that if we had removed only the cavernoma, the patient would not be seizure-free, okay? Because we would not, if based on the structural abnormality, we would have removed only the posterior part here and not the anterior part of the superior temporal gyrus and of the insula. And so for this patient, we have a follow-up of 5 years. Is Engel 1A in monotherapy. Is in monotherapy because later on in the course of the monitoring, the patient had independent mesial temporal seizures, okay? Probably because of the kindling of these mesial temporal structures. So I'm quite reluctant to remove all the anti-epileptic drugs. So here we have a situation where the epileptogenic zone extends beyond the MRI visible lesion. So again, a resection that would have been based on structural abnormality would have failed. And that's why we need functional definition of the epileptogenic zone. So my conclusion and the take-home message, which is the founding principle of epilepsy surgery, is that epilepsy surgery is functional surgery, not lesional surgery. And that's why building an epilepsy surgery program requires neurologists, neurophysiologists specialized in epilepsy, epilepsy monitoring units, and a careful interpretation and analysis of electroclinical correlations. And SEEG, as well as phase 1, allow both delineation of the epileptogenic zone and the assessment of its residual functionality. This is a part of the topic that we do not have time to address. And even in cases with negative MRI or extended lesion or multiple MRI abnormalities, or with presumed epileptogenic zone in the vicinity of highly functional cortex, pre-surgical workup is possible and epilepsy surgery, curative epilepsy surgery is possible. Thank you very much for your attention. And just for those of you who don't know Nancy, and I guess this is the majority of you, Nancy is in the eastern part of France, here close to the German, Luxembourg, Belgium border, in a region called Lorraine. And here you have the beautiful place Stanislas in the heart of the city. This is not the view from the window of my office, unfortunately. And here the entire the list of all the people that are involved in these in taking care of all the patients. Thank you very much for your attention. I am late. I told you, Brenda, that we would be late. But still, I'm open to any question from the audience. I have some time, so feel free to ask your question.
Thank you so much, Professor Maillard, for this fascinating presentation. Francesco, do we have any questions from the audience?
Yes, thank you for your presentation. It was really good and interesting. So basically, I have a couple of questions for you. Actually, 3 questions. The first one is, how do you differentiate the epileptogenic zone from the propagation network? And do you use index of epileptogenicity or something else?
Thank you for the question. It's a very the question is very very good. I'm afraid that the answer will be more complex. We use different characteristics, and one of these characteristics to differentiate indeed the propagation zone is the initial pattern of the seizure. And there are very different ways of quantifying this initial pattern. As you know, there is the gamma index, which basically focus on the rapid activity, very fast activity. The other one, which is the epileptogenic index, which is a way to quantify the power of the rapid discharge, but also the suppression of the slower activity, and integrate also. It consider also the timing, the delay of involvement of the electrodes. And the third one, which is also very important and which has been described originally by Patrick Chauvel and Alicia, I don't remember the name of the first author, but which is what Patrick called the fingerprints, which is in fact a pre-ictal spiking, and then you have a slow DC. You have a slow DC shift, which is surrounded by a very rapid discharge. And this rapid discharge, is, if you look at the in the time frequency domain, it has the same profile as the time frequency domain of a chirping, of a bird chirping. Okay, so which is so sometimes we use them, but not always. But what we use are the concepts that are behind these ways of quantifying. So you can also visually assess the drop of power in the slow band of the rhythm, and the increase of power of the rapid discharge. So this is something that you can quantify, but that you can see also visually using appropriate filters. And indeed, the characteristic of the initial discharge, and not just considering the rapid discharge, but and maybe that's some, for me, a weakness of the epileptogenic index is that it does not take into account the preparation of the discharge, and especially the pre-ictal reinforcement of spiking, which is very important, like, for example, in hippocampal sclerosis, but also in dysplastic tissue. But not only, we will also consider the area where electrical stimulation, low intensity, can reproduce the seizure, not the symptom or not something that will approach the seizure, but the seizure. So electrically induced seizure, and considering and it is very important to compare the electroclinical characteristic of the electrically induced seizure to the spontaneous seizure, okay, to make sure that this is not artificial. We will consider also, especially if you suspect a dysplastic tissue, you know that there is a very frequent concordance between the interictal activity and the epileptogenic zone. So we will also take into account, in some cases, the interictal activity. So that's why defining the epileptogenic zone and differentiating from the propagation zone is not based only on the seizure onset pattern. Okay, you have to take into account many other parameters that will allow you to delineate more accurately the seizure, the epileptogenic zone. The second question was? No, there was no second question. Yeah.
Well, so basically we have collected another one at least. So even regarding the basically, do you use echocardiography during resection?
Okay. Very infrequently, very rarely actually. Very rarely. It can be useful, for example, if you have evidences that the extension of the dysplastic tissue or of the epileptogenic zone on the convexity is more important than the extension in the depth of the sulcus. And then if you have the feeling that the extension of the convexity was not well covered with the EEG electrodes, it can be useful. And we will use it also when we are very close to primary motor cortex, for example, to apply cortical stimulation during. So we will use them both for recordings and for stimulation in awake surgery. But apart from this very precise situation, when you do a EEG, you don't need electrocardiography in most cases, because in fact your EEG will give you the functional mapping, the delineation of the epileptogenic zone, which will be based on all the parameters that I previously mentioned. So whereas the electrocorticography, first of all, it's during surgery, so after infusion of anesthetic, and second, you only have interictal activity, whereas during EEG we have all the information about interictal, ictal, clinical semiology. So somehow I would not skip the EEG to do corticography, perioperative corticography. When you have done, when your EEG is very much consistent with all the data from phase 1, electrocorticography really will add some length, unnecessary length to the resection procedure. So to me, it is not worth doing it. And there are some very few cases, in my view, where it can be useful, but there are very few.
Okay, thank you. So just let me ask you the last two questions, and then I believe that we can also close the webinar today. So, but I believe that they are interesting. So basically, the first one is, do you use HFOs in the interpretation of stereo EEGs?
No.
Okay. And very, very quick answer, so really good. And the last one, basically, do you electrically stimulate all the implanted stereo EEG contacts or only some of them?
We do a selection. So stimulation has two purposes. First of all, delineate the epileptogenic zone, understand the emergence of semiology. So we will stimulate, of course, the presumed sites of propagation, the presumed site of seizure onset, and this is for the purpose of delineating the propagation and the epileptogenic zone. Okay, and then we will also map. We will also do a functional mapping, individual functional mapping of the critical area that will have to be spared eventually or not during surgery. As you know, the deficits that are induced by a high frequency stimulation are somehow reflect somehow the critical characteristic of this area and somehow predict. It's not so simple, but this would require an entire lecture about that, but it will somehow help you to predict the functional outcome. So to answer more precisely the question, no, we don't stimulate all the sites. And for example, you can very simply, you can discard the sites that are in the white matter in most of cases, because you will induce effects that you don't necessarily understand because of the extended effect of the stimulation. So usually we do stimulation in the cortical sites or at the white gray matter junction, and no deeper in the white matter. And then when doing the functional mapping, we will of course focus on the epileptogenic zone to determine whether it is still functional or not, and on the pathway for the neurosurgeon to access the resection, to access the epileptogenic zone. So we don't stimulate everywhere. There is a strategy of stimulation where we choose the sites of interest.
Okay, well, thank you. Thank you, Francesco. Thank you, Professor Maillard, also for the questions. Really, really interesting. So on behalf of Natus and the Neurotraining Academy, it's been a pleasure having you join us again. I would like to thank our speaker, Professor Maillard, for this really very, very interesting presentation. You can tell by all the questions. Thanks everyone for your participation. Enjoy the rest of your day or your evening, and we certainly look forward to seeing you next time on the Natus Neurotraining Academy. This concludes our presentation.
Thank you, Brenda, and thank you to the audience for attending this course. Epilepsy pre-surgical investigation are fascinating, and I hope that you all feel the same as I do about this activity.
Thank you so much. Have a lovely evening. Bye.
Bye-bye.